Welcome. My name is Mitch Sanders. I'm the past chair of the Wound Healing Society Communications Committee. I'm here along with my colleague and current chair of the Wound Healing Society Communications Committee and board member, Kyle Quinn. Today we have a very special guest with us, Dr. Elof Eriksson. Elof is a professor emeritus at Harvard Medical School and chief medical officer of Applied Tissue Technologies. Today we are covering the perspective article Chronic Wounds Treatment Consensus, and Kyle will kick off the questions. Elof, welcome.
Thank you very much. I'm honored to be part of this.
Yeah, thanks for being here. And I think our first question is a little bit about this panel. And could you tell us how and why this meeting came about?
It's a good question. The Wound Healing Foundation recognized the need for an unbiased consensus in this area. So we organized a panel with 13 participants, and interestingly, everybody said yes, and spent a Saturday, very full Saturday on this topic, and nobody was paid for it, and we tried to make everything as unbiased as could be, and later the proceedings were published in Wound Repair and Regeneration.
I'm surprised it only took one Saturday to get through all of that and a consensus on a lot of these topics.
Well, thank you. I think we were reasonably efficient, and we had asked people to come in as prepared as possible before.
Yeah, and so the panel covered topics ranging from diagnosis, debridement, infection control, and dressings. Was there a general topic that was more challenging for the panel to come to a consensus on?
That's a good question. I would say that oxygen treatment was number one there. And as you know, the literature is all over the place when it comes to recommendations about oxygen treatment, and we saw that reflected in the panel. I think everybody agrees that, for instance, diabetic foot ulcers, Wagner 3 or more, is a clear indication, but beyond that, or wounds that are threatened with an amputation, I think beyond that, there isn't a complete consensus.
Yeah, in fact, I had prepared a question related to hyperbaric oxygen therapy, and I think you pretty much addressed that already.
Thank you.
Yeah, because clearly that is a controversial topic.
What about topical oxygen? I know you didn't talk about it, but some of the clinical studies recently have been relatively promising. Is it too new to have a consensus on that?
There have been a number of discussions and reviews on that, and it doesn't seem like people can completely agree. In theory, I think topical oxygen is a lot more interesting than hyperbaric oxygen because it doesn't carry many of the potential complications of hyperbaric oxygen, both for the patient and for the treating wound care practitioner.
So switching topics, could you talk about the general consensus on how to select a dressing? I know that's kind of a complicated topic, but
we spent a good deal of time on that, and I would say that to begin with, we want every dressing to provide a moist environment and one way or the other prevent the proliferation of contamination in the wound, which may be done by the dressing itself, or it may be impregnated by something, or you may need to add an antimicrobial under the dressing. Once you have done that, I think you need to look at what, in addition, the wound needs. If there is a high level of exudate, obviously you need a highly absorptive dressing. And if you need to immobilize the wound, you need a splint or a cast. For venous ulcers, for instance, you need a compression. So it does depend to a great degree what the wound needs. If you have a completely uncomplicated, clean, non-exudating wound, you can use just about anything. And as long as the environment is moist, it is going to provide an optimal environment for the healing.
I thought it was nice that the consensus panel talked about it'd be nice to have not just Me Too products, but really advances in dressings. And there's a real, the issue is that there's a lot of companies that just follow a 510K and get a Me Too product out there with no differentiation or no clinical evidence that it's any better than the rest.
That's a very good point, Mitch. And I think that many wound care companies, particularly the big ones, they have to look at the bottom line. And many of them think that research into new innovative product doesn't pay off. So they expect small startups to handle that. And then they watch it swim or sink. And if it's successful, they would rather pay a little more for that ready product than to develop it themselves. I wish that it wasn't that way, because many of the big corporations have huge research facilities, and they could do it. So I hope in some way we could stimulate them to do more research into providing new products rather than Me Too ones, as you said.
I also think that the FDA is raising the bar and asking us all to do more studies. And so it feels like our 510Ks of today are more like a PMA than they were 5 years ago. So the bar is getting raised.
You are absolutely right. And the old saying that the FDA is easy to get into and much harder to get out of, that's getting more true every day.
Well, while we're on that topic, I guess, we could talk a little bit about surrogate biomarkers and endpoints. That's obviously a major concern in drug and device development. And could you talk about some of the important outcomes beyond complete wound closure that the panel agreed on?
There aren't many good ones. And the ones that stand out, for instance, in what we see as an acute wound would be how the wound progresses toward healing during the first 4 weeks of optimal treatment. And we expect the literature differs. The panel thought that there should be an improvement, a decrease in surface area of 50% or more in order for that wound to be likely to progress normally. But of course, if it's taken more than 4 weeks, the wound is already chronic. And the panel also agreed that if a wound doesn't move toward healing significantly in 4 weeks, there should be a reassessment of the method of treatment. As you know, in various studies, percentage healing and not complete healing has been used as a surrogate for healing. And that's perhaps the only true surrogate that at least I have seen out there. There are many potential ones, but none that has gained universal acceptance.
I did want to ask about cell tissue products. I know the section was very, very small, just because you can only put so much in a guidance document, right? But I think the take-home message was that the clinician really has to look at the clinical evidence of a specific product, as well as the clinical indication, whether it's for DFUs or VLUs. Because I'm seeing just in placental-derived tissue, everybody's minimal processing really does matter. And so you really need to look at their clinical evidence of the benefit of their product before you decide on and these products can be quite expensive too. So they really have to have clinical evidence that the product's going to be beneficial.
That's a very good question. And the way you formulated the question, you pretty much answered it too. So that I agree completely with what you said. There's no question that in most wounds, cell and tissue-based products are very useful, but we do need to find some unbiased comparisons in order to come up with recommendations on which ones to use when, because I don't even know how many there are in the marketplace now, but there are quite a few.
Almost probably a little bit more than 200 now, right?
I would have guessed something like that. And there's no question that they are helping wound healing, but as you touched upon, which ones, for instance, are the most cost efficient in this or that situation?
Yeah, and I do see that the CMS, for instance, and the MACs, they're kind of approving these products for VLUs and DFUs, but they're not indicated for pressure ulcers. And usually they want you to try something else first, and when that fails, then you can move to CTP, a cell tissue product.
That is true. So I agree with you. We have some work to do, and I think a consensus panel on this topic alone would be very worthwhile.
Yeah, it would certainly take up a full paper.
It would.
So I do a lot of work outside the U.S. and I was just at the European meeting, and I see there are subtle differences in the consensus documents for Europe and U.S. They do seem to be getting closer. Are there still a lot of differences, or is it's just more around offloading and things like that, or what else do you see that are differences?
It's a good question, and I agree with your statement. And I think most of the consensus work right now comes out of EWMA, European Wound Management Association. And if you look at what they are publishing, they are, for instance, not recommending negative pressure for incisions as much as we are here. So you clearly see a difference there. Another area is what we talked about, negative pressure, oxygen treatment, where they are a little more skeptical than we are. And there are some other areas. Overall, I think that the treatments and the algorithms they are using is much more similar than not to ours, but with a few differences.
The other thing that I love about EWMA is they've come out with training documents for nurses and clinicians who are just jumping into the field, and they've really, some of those documents are just priceless because, oftentimes, especially in the States, we have a lot of clinicians coming into wound care secondarily. You're kind of the exception to the rule where your entire career was wound care, whereas there's a lot of physicians that were general surgeons that then became, started doing wound care.
Very well stated. I think the Europeans are much more training oriented and protocol oriented than we are.
Interesting. Well, I really appreciate having you for this fireside chat, Elof. Can you tell us a little bit more about your current things that you're doing in your company and other things that you're working on?
Well, thank you for asking. My research today is entirely dedicated. It's entirely sponsored by the Department of Defense and directed toward providing better treatments immediately after wounding. And, part of it is related to changing strategies in warfare, and compared to earlier campaigns, Vietnam, Iraq, Afghanistan, where they had the wounded warriors at a field hospital within half an hour. Now the fighting unit is much smaller and isolated. So the buzzwords are prolonged field care and delayed transport. And what I'm working on is trying to come up with dressings that protect the wound, delay or prevent the onset of infection, and reduce pain. That's all. And as a base for that, I'm using polyurethane membranes. And you want something that is lightweight, sterile, has years of shelf life, can be carried and put on by the wounded warrior himself or herself, or a teammate, because in these small groups there aren't any medics anymore. So there are very specific requirements for how these dressings should look. And by the way, they are in essence similar requirements to the ones that we need for catastrophic events, such as a nuclear catastrophe, where the problem for most of the survivors is medium or deep partial thickness burns.
Wow. I actually ventured off wound care for a project this past 2 months. I've been working on traumatic brain injury. And what's really interesting is it all comes back to the same phases of healing. When you have an injury, you have these kind of initial phases of the inflammatory phase, and then you have these chronic responses. And in traumatic brain injury, you have all these chronic disorders post-injury that may never heal. But it's just like a delayed wound where you have a stalled inflammatory phase. So it's pretty interesting how everything seems to come together when you're studying injury,
I like that comparison. That's a very interesting way of putting it.
And what's interesting in the brain is there's a whole class of these antigen-presenting cells that crosstalk with the microglia and the macrophages, and they, through the lymph, they get all around the body, and they can change very large systemic effects from an injury from the brain, which is pretty amazing.
You are quite right. However much we learn about wound healing, it will still be variations on the inflammatory reaction, by and large.
Exactly. Anyway, I had a wonderful time for this fireside chat, Elof, and thank you kindly for joining us. And I'll let you know in a week when we post it to the website. And it was tremendous to see you file as well.
Yeah,
Thank you very much for having me, and I'm honored to be part of this. Thank you.
Thank you kindly. Take care.
You too. Bye.
All right, bye.